everybody, and welcome. Thank you for joining today's virtual education workshop at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled, Cervical Health Awareness. Before we begin, if this is your first time joining us, CSC South Bay's is a premier nonprofit organization providing social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our program includes support groups, healthy lifestyle classes, social activities, and educational programs such as this one. We'll provide more information about our program and service at the conclusion of this workshop. If you'd like to learn more about us, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. You may, however, enter any questions into the chat feature at the bottom of the Zoom window at any time. And hopefully we can get to as many questions as possible. Dr. Priya Mitra started her career in internal medicine and then transitioned to radiation oncology in 2007. She currently works at UCI Medical Center and treats all cancers with a specialized focus in women's cancers. It gives me great pleasure to welcome today's speaker, Dr. Mitra. Thank you so much for being here with us today.
My pleasure. Thank you so much for having me, and thank you all for joining. Happy New Year. Let me share my screen. You can see the full screen, correct?
Yes, correct.
Okay, great. So I'm going to get started. So January is Cervical Health Awareness Month, which is why we thought this would be an appropriate time of year to discuss cervical health. My name is Priya Mitra. And just a little bit of background about myself, a little bit Rebecca touched on. I did my internal medicine residency in Boston at Boston University Medical Center. And then I subspecialized in radiation oncology at Virginia Commonwealth University in Richmond, Virginia. I then spent about 10 years working in Philadelphia. I worked briefly for a few years at USC in LA, and then have now established myself at UCI in Irvine, where I focus on primarily women's cancer, so breast and gynecologic. So when I was thinking about prepping this presentation, I kept thinking, how do I cover everything there is with cervical health? So I thought, why not go through the who, what, when, where, and why, as well as how, all about cervical cancer. So at any point, if you guys have questions, I love questions. Feel free to mention it into the text group, and happy to address as we go, or also at the end, we'll have time for questions. So who gets diagnosed with cervical cancer? What is cervical cancer? When should we take action? And where is it most common in the world? Why is it very important to take seriously, and how do we treat it? So these are the questions that I'm going to focus on as we go through the topic today. So who gets cervical cancer? So in the United States last year, approximately 14,000 new people were diagnosed with cervical cancer. Approximately 4,000 women died of cervical cancer in the United States last year. The interesting thing about cervical cancer is that it has what's called a bimodal peak, meaning that there's typically two age ranges where cervical cancer patients typically present. Specifically, excuse me one second. So in their 30s, and when women are in their 60s. The women in their 30s often present with early stage disease, and 60s often present with advanced disease. But again, those are just generalizations. It's certainly not the rule. So what is cervical cancer? So just a little bit of anatomy review for reference. So here's the picture of the female reproductive system. We've got the uterus or the womb. This is where babies will grow. You've got your fallopian tubes, which are connected to the ovaries where our eggs live. The endometrium is the lining, the inner lining of the uterus. That's what sheds when we menstruate and have our periods. And then the cervix is the opening, which is the bottom of the uterus, also known as the cervix uteri. So, and then that opens up into the vagina. So the cervix is what dilates when women are in labor and the baby can come out. So cervix, this is looking at the anatomy kind of from a side view. So just to orient you, here's the sacral bone right here. On the front, this is the front of the body. And then this white piece right here is the pubic bone, which you can feel like in your lower pelvis. So here is the uterus, and it's sandwiched right in between the bladder and the rectum. So a lot of times when we're talking about symptoms, which we'll talk about later, symptoms from cervical cancer, many times women will come in and say, I feel like I feel pressure on my bladder. I can't keep my bladder, can't get it very full. I have to empty it. And same thing with the rectum. Sometimes the cervical cancers, again, at the bottom here, are pushing backwards, making it hard, making them constipated or making the stool change the size or shape. So here is the cervix. The cervix actually, when you look at it, looks like a mini donut. So on the top left is a picture of what a normal cervix looks like. Very smooth, glistening, clean. And then as tumor develops, it typically starts as a low-grade, non-invasive tumor. And you can see it just kind of looks a little bit like those whitish spots. And then it starts to get a little bit more aggressive and becomes a high-grade cervical intraepithelial neoplasia, which you don't have to remember that, but just to show you the progression, and then it can develop into cancer. So what is cervical cancer? Basically, it's abnormal cells in the cervix. They typically start as precancerous cells, which is typically detected on pap smears, and most cases are HPV related. So what is HPV? HPV is human papillomavirus. Basically, it's a virus that has multiple strains, over 100 strains, and they can cause benign and cancerous lesions. However, only a few or handful of high-risk strains can actually lead to cancer. HPV is the most common viral sexually transmitted infection. So as opposed to gonorrhea and chlamydia, for example, those are bacterial. This is a viral infection. Most people who are not vaccinated and sexually active will develop or get an infection with HPV at some point in their lifetime, but rarely know that they have it. Oftentimes, your body just clears it up on its own. However, if it does persist, it can turn into abnormal cells, which can then progress to a cervical cancer if it's not detected early enough. So how do we transmit HPV? I think this is an important thing to talk about because I don't think we talk about this much in our sex ed classes. So it's typically skin-to-skin contact so it's intimate skin-to-skin contact, so intercourse. Oral sex is a way you can transmit it. In fact, there are HPV-related throat cancers that you can get. So that's one thing to be aware of, anal sex. But just so you know, you do not have to exchange bodily fluids for HPV transmission to occur. Hand to genital contact is a rare cause of transmission for HPV. It's really the ones that I've highlighted here: intercourse, oral sex, and anal sex. So where is cervical cancer located in the world? So I find this really interesting and staggering that, as I mentioned earlier, about 14,000 new cases are diagnosed in the United States every year, and globally 600,000 new cases are diagnosed. So significant difference. And you can probably imagine why. In a lot of the third world countries, underdeveloped countries, that's where 85% of cases are found. And the thing is that those women are not getting vaccinated with HPV. They are not going in for routine pap smears. And so a lot of those women come in with cervical cancer. It's the most diagnosed cancer in 23 countries, but it's not even in the top 10 of all cancers that affect women in the United States. And it's the leading cause of cancer death in 36 countries. I had the privilege of going to South Africa a few months ago, where I visited a hospital where they are treating a lot of cervical cancer, and it was actually an African conference, and the vast majority of the countries that were represented there said that half of the patients that they see have cervical cancer, as opposed to here in the US, that's nowhere near the numbers that we see. So this is just a map showing you the distribution of cervical cancer in the world. The darker the color, the more heavily it occurs. So as you can see in middle and southern Africa and Western Africa and parts of South America are really, there's a high incidence of cervical cancer, less so in the United States. So when should we take actions? So first off, HPV vaccines has become pretty universal for children. So dose 1 and dose 2 are given typically around the ages of 11 to 12. These kids should get 2 doses about 6 to 12 months apart. You can give a vaccine as early as age 9. If a child is, or young adult is above the age of 15, then they need to get 3 doses. And if you have a teenager in your life, I would encourage you to, discuss this with a parent or relatives. So, one other common thing that I think we don't talk about is that teens and young adults can be vaccinated too. So the HPV vaccine is valid for everyone up through the age of 26 if they've never been vaccinated. HPV vaccination is not recommended for everybody above the age of 26. In Canada, the last time I checked, that they were giving it up to 45. So as this specifies here, some adults ages 27 to 45 who are not already vaccinated may choose to get the HPV vaccine. So I'd encourage you, if you're in that age range, to think about it and talk to your doctor. I can share personally, I chose to have the vaccine because I was beyond the time when HPV vaccination at ages 11 and 12 became mainstream. And so as an adult, I chose to get it. Obviously, I'm biased based on what I see and what I treat. And I'm a big believer in the vaccine, which is why I got it. And it's given me some peace of mind to know that, the odds of me developing an HPV-related malignancy is extremely low. So who gets 3 doses? So as I mentioned, if you're 15 or older, a 3-dose schedule is recommended. And again, they should be given over a span of about 6 months. And you want a minimum gap of about a month in between, and a longer gap between the second and third. Screening guidelines. This is a very busy slide. I'll simplify it on the next slide, but I just wanted to, basically the takeaway from this slide is that there's different organizations that give us guidelines in terms of how we screen for cervical cancer. The USPSTF is the United States Preventative Services Task Force. So, and then the American Cancer Society. So these guidelines are from different years, but the general trend is the same. Basically, when women are in their 20s to 60s is the age that they recommend screening for cervical cancer. So the USPSTF says in women when they're in their 30s, or excuse me, when they're 20s, they should get a PAP every 3 years. Once they cross 30, then they should probably have co-testing of PAP and HPV every 5 years, or PAP every 3 years. And then American Cancer Society essentially is saying the same thing. If you are a woman who's had a hysterectomy for a benign reason and the cervix was removed, those women typically don't get screened with Pap smears. So Pap smears and pelvic exams. So again, just to summarize, Pap smear every 3 years. It used to be every year, but it thankfully has changed to every 3 years. Or you could get a PAP and HPV co-testing every 5 years, meaning at the time they do their PAP, they check for HPV. And then if they find an abnormality either on the Pap smear or the HPV testing, then they would recommend more frequent screening. That being said, it's important to still go for an annual pelvic exam because these Pap smears are great and HPV co-testing is great, but doing a pelvic exam is really important too. I didn't insert a slide, but I wanted to just touch a little bit on symptoms. So when to really take action. So symptoms of cervical cancer most commonly include vaginal bleeding in between your periods if you're menstruating, or bleeding when you're, in menopause. So unexplained vaginal bleeding, bleeding associated with intercourse, or what we call postcoital bleeding. So meaning after intercourse, it not very common to have bleeding. So if you do, that's something that you should bring to the attention of your healthcare provider. Pelvic pain. Now, pelvic pain is a very generic symptom, but if you're having pelvic pain or cramping that's unusual, again, that should prompt you to go for a pelvic exam to get checked. The first step that they typically will do is do a pelvic exam, and then sometimes we'll start with doing a ultrasound where we check the inside of the vagina and the cervix and the uterus to see the anatomy and the how it appears and if it looks normal or abnormal. But yeah, vaginal bleeding is the main thing to be mindful of. So why is it important to take this seriously? So I think these are the main things. One is that cervical cancer is extremely preventable. I believe and am seeing that we're seeing less cervical cancer patients as the population of people who are vaccinated is growing. So HPV vaccines is helping to prevent this. And there's obviously talks about bringing vaccines to the third world countries to help make it more preventable there. It's detectable. It's very relatively simple. You go in for a pap smear, you have your pelvic exam, and it can be found and treated. It's very treatable. Sometimes it can be just done by treated by an in-office outpatient treatment, and we'll go through some treatment options later. And it's very curable. This isn't, women should not be having, women shouldn't die from cervical cancer. If we catch it early and prevent it in those that we can, it really has excellent outcomes. So any questions so far before I shift into treatment?
If you have any questions, feel free to put it into the chat. Yes, Angela, let's go ahead.
No. Well, now that, okay. How about if you're past 65? Let's say you're 67.
Yeah, that's a great question in terms of screening, correct?
Because they screen up to 65.
Yeah, no, I mean, that's an excellent question. And, I struggle with that too. I don't know the right answer to that. I think that's one where I would talk to your provider about it and they would assess your risk. It's interesting with the bimodal peak, with the second peak of incidence being in your 60s, and then the guidelines say to stop at 65, doesn't really make sense to me. So, I'm a big fan of screening because if you screen, then that's how you find abnormalities. But yeah, I think that's something, if you're between the 65 to 70 age range, I would encourage you to talk with your provider. I would definitely continue at least getting your pelvic exams. But pap smears, I think, is an individual decision.
Thank you.
Yeah.
I think we're
Okay.
good at questions. Thank you.
All right, great.
Oh, there's another question if you're okay with it.
Absolutely. Yeah, for sure.
Does the chance go up if you have breast cancer and HPV?
Breast cancer and HPV. So no, those are unrelated. So just as a quick aside, breast cancer and ovarian cancer can be linked. So in women with the BRCA mutation or BRCA mutation, those women are at risk for having both breast and ovarian cancers. There's not a genetic mutation associated with cervical cancer. Like the vast majority, over 90% of cervical cancers are HPV related. So it's a sexually transmitted virus. So the key is really, to use safe sex practices and go in for your checkups. I hope I answered your question.
Thank you.
Yeah. All right, let me share my screen again. All right, so how do we treat cervical cancer? So the key with cervical cancer treatment is, how soon is it caught? If it's caught very early, the first thing that a gynecologist will do is what's called a cone biopsy. So it's a cold cone biopsy, and basically what they're doing is they're going in, and usually in the office, they're cutting out what looks like a cone-shaped portion of the cervix. And then they send it to the lab, and they look to see if they got all the tumor out. And if they did, great, then they will continue with monitoring you. If they didn't, it may require more procedures or operations. The next step, depending on size, is what's called a trachelectomy. So instead of removing that cone-shaped, sometimes what the surgeons will do is they will remove what's here in the dotted blue line. They'll basically remove the cervix, and they put in a stitch to leave the uterus intact. This is not a surgery that's done very frequently that I've seen. The primary objective of this surgery is to preserve fertility. So if you have a young woman in her 30s who gets diagnosed with cervical cancer and either has no children or wants more children, but doesn't want to lose the uterus, this is sometimes something that can be done. That being said, this has to be in a situation where the tumor is caught early. I've honestly had women come in with 7-8 centimeter tumors, and something like that, we're not going to be able to just remove the cervix. So it needs to be small, it needs to be localized, it needs to be a very early stage. Again, which is another reason why catching things early is really, really helpful. So this is called a trachelectomy. So the next step would be, meaning if it's more advanced, would be a hysterectomy. So there's different types of hysterectomies. Partial hysterectomy is pretty rare. I honestly don't see that happening very often. A total hysterectomy is basically, so the white dotted line is what is being removed. So again, just as we talked about anatomy, just to reorient, here's the uterus. That's where the baby will lie in the inner lining. The cervix is the bottom, and then here's the vagina. We've got our fallopian tubes and ovaries on either side. So in a partial hysterectomy, this white dashed line is what's being removed, basically the top of the uterus. Total hysterectomy is they remove the entire uterus, but they leave the vagina, they leave the fallopian tubes and ovaries behind. A radical hysterectomy is what's typically done in advanced cervical cancers. If it's a really early stage cervical cancer and the patient does not desire fertility preservation and they need more than a cone biopsy, this is what'll be done. They'll just remove the uterus and cervix in its entirety, probably a little portion of the upper vagina as well. Radical hysterectomy removes it all. And again, this is if something is caught late and it's more advanced. This is not super late, but a little bit more advanced than what's eligible for a total hysterectomy. So another option is radiation therapy, and that's what I do. I am a radiation oncologist. So there's two different types of radiation treatment. So the first type I wanted to talk about was external beam. So basically, this is a snapshot of a patient laying on a table, and this is a machine. It's called a linear accelerator. And then we have radiation therapists, which is what's pictured here on the right, kind of blurred out, where the person is operating this machine. So this machine, this is the head of the machine. Hopefully you can see my arrow moving. The radiation comes out of this, this little window, and it's aimed almost like a laser at the part of the body that needs radiation treatment. And it can get very, very pinpointed and very focused. So in a cervical cancer patient, as I mentioned, like if I have a woman who comes in with a 6-centimeter tumor, then she's probably going to get a combination of external beam radiation, which is this, and internal radiation, which I'll talk about in a moment. The external beam radiation is aimed at the pelvis, and what happens is that they come in every day, Monday to Friday, 5 days a week for 5 weeks to get the radiation treatment. The treatment does not hurt, and it's pretty quick. It only takes about 10 minutes, so the worst of it is just coming in every day. But again, we don't need to do this type of treatment if it's caught early. This is really more for advanced patients. In the example of an advanced patient, in addition to the external beam, we also have to do internal radiation, and that is called brachytherapy. So in the middle picture here is a device. These are metallic applicators, we call them, or instruments that go into the vagina, into the cervix, into the uterus. So on the right is probably a nice picture to start with, actually. So this is we call it tandem going into the uterus. And then you have these pieces on the side that are called the ovoids. And inside each of these green lines is hollow. So into them, we put something radioactive, and it gives off a cloud of radiation, like this orange cloud. And that is how we give radiation from the inside out. A lot of people will ask, well, why not just do it all externally? Why do you have to do it internally? The issue is, with external radiation, it's like a flashlight. If I were to shine a flashlight on my finger, the light goes in and out the other side. Very similar, the external beam goes in and out the other side. But what's in the path, as I showed you with the anatomy, the bladder and rectum are right there. And they can only handle so much. So it's safer to do some this way, shrink the tumor, and then we do the internal radiation where we put these instruments inside. We typically do these anywhere between 3 and 4 times. It's also outpatient. Everything here is outpatient and generally well tolerated. There's also chemotherapy and or immunotherapy. So in women with advanced cancers, again, who have not had their vaccine, who have not come in for checkups and come in with a bleeding large tumor, they typically will get a combination of the radiation I just described and weekly chemotherapy. Sometimes if it's advanced, we'll add immunotherapy too. It's basically a medicine that's given into your eye intravenously and goes into the body to help the radiation work better. They work together as a team, and it also helps attack the tumor and keep it from spreading. And this is typically given once a week. The good thing about the chemo that we use for cervical cancer is that it does not cause hair loss, unlike a lot of other types of chemotherapy. Now, we've talked about a lot of different treatment options. There's also the possibility of using treatments in combination. So sometimes women will go for surgery. They'll go for, let's say, a hysterectomy, and they think that that's all that they need to do. But then when they look at the results in the lab, they find that the patients had more advanced disease than was anticipated. So in those women, sometimes they need radiation therapy afterwards, and sometimes even both radiation therapy and chemotherapy. We do our best to screen these patients and appropriately send the ones to surgery that we think have really early stage disease. Another possibility is, and we kind of talked about this already, is that radiation therapy is very commonly used in combination with chemotherapy and or immunotherapy, and that's in locally advanced cases. It's rare that we do radiation therapy alone, but it is sometimes a treatment approach. So in summary, those are the questions that I wanted to get through. So who gets diagnosed, what it is, when we should take action, when to present and call your provider, where is it most common in the world, why is it important to take our cervical health seriously, and how we treat it. So I wanted to thank you all for your attention and open the floor up for questions.
Wonderful. Thank you so much. If anyone has any questions, feel free to put them into the chat, or you can also unmute yourself if you would like. And while people are typing things out or thinking of questions, this workshop is being recorded. So if you would like a copy of this recording so you can review or share with someone who might be interested in this information, feel free to email me at rebecca@cscsouthbay.org, and I can get that recording over to you. But thank you so much, Priya, for your meaningful presentation. It's so important to be, knowledgeable and empowered so we can better support ourselves.
Yeah, I think that's the biggest thing about cervical cancer that I love, is that we as women have a lot of power and control. You can choose to get the HPV vaccine as an adult. You can choose to go get your pap smears and your HPV testing, and this can be caught early and treated really early. So you don't have to go through the long, hard treatments of chemotherapy and radiation therapy.
Absolutely, absolutely. And like those visits, the yearly visits or every 3-year visits are hard, but they're like the dentist.
Yeah, and a lot of women shy away from seeing an OBGYN. And I would just like to share that sometimes a lot of primary care doctors also will do pelvic exams. So if you have a primary care doctor that you like and trust, I would encourage you to ask them and see if they do pelvic exams and or pap smears. That's can be helpful, or the opposite may be true too. I've seen a lot of OBGYNs who do pap smears and become the primary doctor for women. They're the ones referring for mammograms and checking cholesterol and doing the basic screening for other conditions. So the key is finding somebody that you're comfortable with and that you are happy with, that can help walk you through the journey.
Wonderful. All right. If there aren't any questions, thank you so much, Priya, for your time today and for sharing your expertise with us, and also everyone for attending. So just a reminder again that if you would like the recording, to please email me, and if not, I hope to see you at another program at CSC South Bay. Thank you.
Rebecca, I love